EM board bombs.
Welcome back to EM Board Bombs. I am here with Dr. Briggs. This is Dr. Wasiski, and we're going to give you 5 rapid bombs here, just some quick hits for the boards. And if you love these, you should sign up for the premium pod where you'll get plenty more like this. We're going to do 5 more just for our premium subscribers.
EMBoardBombs.com. Check us out. We have a merch page we just started. Heck yes. Mugs, t-shirts, stickers. Check it out. Sweatshirts are nice and comfy and cozy.
Mm-hmm.
I wear mine almost every day. Embroidered as well. Pretty sick stuff. High quality things. Thank you for those who have ordered stuff. Thanks for supporting the podcast. Everything goes to just supporting and keeping the lights on, basically, like to say, and repping the ED. How about that? Why don't you lead us into this first pearl here?
Yeah, so first pearl here. So you get an EKG and you see the QRS amplitude alternating beat to beat. What do you think?
Yeah, I almost hate that we gave this because it's just so obvious that when you see beat to beat alternating amplitude, I feel like everyone would select in a multiple choice test it's some type of like tamponade or fluid filled pericardium because it's interfering with electroactivity. Sure, it's not artifact, it's electrical alternance. What we should have done instead is said you get an EKG, they're tachycardic, but it's low voltage. I feel like that would have been much more of a cool, interesting pearl because I feel like a lot of people take a low voltage EKG and they say, okay,
yeah,
whatever, and they sign no STEMI and they move on. But I would say the top 3 things for low voltage: one, always think the most life-threatening is a pericardial effusion. Second would be hypothyroidism, depending on if the patient's bradycardic or not, and older, I guess. And the third would be just, positioning of the leads or body habitus would be low voltage related. But those are the top 3, at least I think about. So the problem also with tamponade, we did an episode on this before, is that Bextriad is so unreliable.
Oh, yeah.
And so what is the reality of a lot of these pericardial effusion patients? When you've seen it, when have you seen tamponade, what do you usually see instead?
I mean, maybe one of the things.
Maybe one of them. Yeah, exactly. We're not really typically measuring JVD.
Oh, gosh.
For all obvious reasons.
And honestly, like in today's patient, JVD and muffled heart sounds like body habitus is going to block both of those, interpretation of those anyway. So that's going to be difficult.
Totally. So in this case, really all you have to do is just a bedside echo. I would say that's like the easiest diagnosis you can make in the ED ever. For
exactly. So if I get
diagnosis.
handed a triage EKG and it has low voltage, I just bring the echo in the room with me to examine the patient.
Absolutely. And all you have to do is really just one view. I tell students and residents this all the time. If you're crunched for time or you're doing your rush exam, the subxiphoid or subcostal view is the greatest view you can get. It's like a poor man's apical 4. It tells you a lot of interesting information here. But for the move here of bedside echo, we're thinking pericardial effusion, looking for that RV diastolic collapse, and then you got to think about emergent pericardiocentesis on these patients. Cool. Let's move on to the next one. But first, why don't you talk to us about EM rapid bombs? Because again, if you're getting 5 pearls here and you want another 5, and this happened, in previous weeks too, we gave 5 pearls, and then we give another 5 just to the premium subscribers. What does it take to be a premium subscriber?
Yeah, premium subscribers, you just go to our website, you click the link to sign up for EM Rapid Bombs. You pay a one-time annual fee. It's an easy way to get the Rapid Bombs delivered straight to whatever your preferred podcast streaming service is. And every week you get a couple new podcasts. I mean, we have over 500 episodes. They're like
570. Just
there you go.
Today.
570, 3 to 5 minutes each. Tons and tons of pearls.
Yeah.
And I mean, it's the best way to ace your boards.
Absolutely. So check it out, emboardbombs.com. One-click sign up, and you get amazing amount of content, just what you need to know for the written exam for boards. It's not too much. It's just what you need to listen on your drive-in or walking the dog. It's not overwhelming. We also tell you what you need to know for real life. We coach you and tell you how the questions are going to ask you certain things. It's at an affordable price. It's still cheaper than like lame Netflix. I don't have a Netflix subscription right now. I kind of gave up on it in recent months. But what's amazing about Netflix is now it's like there's like scales of, I sound like such a boomer right now. It's apparently scales of like, you have to pay extra for like 4K or like extra for like high definition. Is that still a thing? I mean, that's pretty insane. So anyway, just keep that in mind that Netflix is still plenty more expensive than our EM Rapid Bomb subscription. So cool. Hey, let me ask you a question. This is something that I love to ask students all the time. Would you give a beta blocker for a patient with chest pain that you just said they literally did cocaine like that day or yesterday, whatever?
On the boards, never.
Never on the boards. Yeah, you definitely can't do it on the boards, unfortunately. But let's say in real life.
I mean, I don't know why I would.
What would you do instead?
Give them Ativan.
Sure.
Or benzo.
Yeah. So the point of this question is, one, it's a debate that doesn't need to happen.
Yeah. Like, why would I do that?
But two, exactly. Two, benzodiazepines are first line, right? And what are you treating? Kind of what are you looking for in these patients with cocaine-related chest pain? Of course, we're still going to rule out, ACS. These patients have a high risk of ACS, higher risk than the general population.
Yeah, ischemia, sympathetic surge, dissection.
Totally.
Yeah, they have unopposed alpha stimulation, blah, blah, blah. Don't give them a beta blocker. Hypertensive emergency.
Totally. Cool. So moving on. Next question.
Headache, vomiting, red eye. It's a little cloudy of a cornea. The pupil is mid-fixed. What do you think? Maybe they just went to a movie theater?
I love when they add that in. They're in a dark room. Yeah, so acute angle closure glaucoma, until proven otherwise. I just did a whole series on approaching the red angry eye, and one episode was on acute angle closure glaucoma. And this is for our Rapid Bomb subscribers only, so they got exclusive access on top 4 causes of a red angry eye that you can't miss. One of those is glaucoma. We're not going to go into the entire details of that because you can catch it on our Rapid Bombs. But just know that the IOP, the intraocular pressure, this isn't like you do it and you're like, oh my God, it's 21. Is that a glaucoma or not? This is like...
Yeah, this is not
this
subtle.
This is like greater than... Yeah, this is usually like 50 to 70. It's pretty insane. You're going to do it and you're going to gasp and the patient's going to be like, what?
Yeah.
So at the minimum, it's going to be in the 30s. How about that? And so the pearl here is you do your visual acuity, which people forget to do a lot. It's literally the vital sign of the eye. And I feel like ophthalmologists immediately judge your consult if you don't give them visual acuity when you call them. So always give an ophthalmologist the visual acuity. And then check the pressure of this eye using a tonopin. The globe will feel like
right,
hard.
you can
the conjunctiva will be injected. Yeah. Yes, it's crazy. It's surreal. But don't try to touch it.
Yeah.
So don't do that. So do a tonopin, and then you're going to do what immediately? You're going to gasp. You're going to see it's greater than 70 millimeters mercury.
And then you're going to say,
what's your first line?
I got to get the drops. I got to
drops.
drop this patient. You're
Yes.
going to get your Timolol drops. That's, yeah.
Bingo.
And the color of the cap of the drop.
What?
They'll test you on the color of the cap of the drop sometimes.
I've
The
never had that question. Tell
ophthalmologist?
me.
You've never
I'm
had the
learning.
ophthalmologist ask you that? I'm not saying the boards.
No,
the
never.
ophthalmologist will.
What type of place are you working at? Quizzing you on the bottle
No.
caps.
Like, get the
You sound like our patients. They're like, I take a little yellow round pill.
get the
Yeah.
orange ones. And then apriclonidine, anything that ends with the ene. Sometimes I've worked places where the only thing they had was atropine to dilate the eye. Something, yeah,
God.
something that's gonna
That's
something
crazy.
that's gonna dilate,
Something that's going to
Yeah.
do something.
help
Yeah.
open the angle.
So Timolol is number 1, though. If that's all you have, I think the WHO recommends Timolol as like one of those, like, the top 100 absolutely necessary drugs in any life-saving
You will have
environment.
Timolol.
Is like in
Yeah,
that list. Yeah, you will have Timolol in
Yeah.
your ED. So you will have that in a critical access hospital. Email us if you don't. We'd love to hear from you and find out where you work. We had a subscriber, shout out, by the way, to rural South Dakota. I had one email us several weeks ago from rural South Dakota. He's the only EM boarded physician for like 90 miles. It's kind of crazy. So good luck to him. Anyway, don't dilate the eye, obviously. You shouldn't be doing that anyway.
And you need the IV acetazolamide.
Yes, except for which population?
Sickle cell disease.
Bingo. Yeah,
Terrible
don't do that.
luck.
Don't do that. Yeah, it's bad luck. There's a lot of bad luck with sickle cell disease. All right, boom, there's an explosion. Think of Lebanon. Wasn't that Beirut explosion that happened like 3 years ago? The videos of that
Yeah.
are crazy, by the way. So big explosion happens, and a lot of people are hurt, and they all start coming to the ED. Some walk in, some are brought in by EMS, etc. Some are flown in, let's say. They did a 5-minute helicopter ride because they thought they had to. So who needs imaging and observation?
Quick screening, check the eardrums. Look for TM
Bingo,
rupture.
that's awesome. The most pressure-sensitive organ. The
And I can tell you, just
So-
living at altitude, that is very true. I see tympanic membrane ruptures here from people easily. They think they're just popping their ears and they rupture their eardrums.
That's
Yeah.
crazy. Now that's a fascinating statistic. Do you ever have people come into the ED that are just wanting oxygen therapy?
Oh God, all the time. I prescribe oxygen from the ED
Yeah, that's fascinating, isn't it?
almost every day.
No, that's like an active Congress to get that done.
Yeah,
here.
it's
So
wild.
I guess you have a
We
streamlined
do.
process.
We have to. Yeah.
That's awesome. That's great. Yeah, here it's like if someone checks in for that, I'm like, I don't know how I'm going to make that happen for you today. Cool. So the Pearl intact TM,
Unlikely severe blast injury if your TM is intact.
very unlikely, at least on the boards. Always judge how the patient's doing elsewhere. And then a ruptured TM, of course, we're thinking high-risk patient. What's the test you need to order, like the ultimate screening test for these patients?
Get a chest X-ray,
Yeah. Totally.
and then
And then you're going to get it again.
6 hours you got to observe them.
Yes. Awesome. Cool. Last one here for the main podcast here. And then remember, the other 5 are going to be the next 5 pearls. If you like these, are for our premium subscribers only. Plus, they get weekly episodes and weekly email blasts over hot board takes. So, what's the number one can't miss sign of a uterine rupture?
Oh, fetal bradycardia.
So scary. I did 2 episodes literally this morning of this day of recording on uterine rupture. But this is just a quick review. So fetal bradycardia, and what are the other concerns you have on the what's thought of as concerning but may not show up right away depending on the patient?
Yeah. So, well, I mean, you don't have pain, you don't have bleeding, because the uterus can rupture up. So
Yeah. And they could have an epidural.
yeah, exactly. So that's
yeah.
why you don't have pain, and then you don't have bleeding because it's rupturing up into the patient. And you're going to have loss of fetal station. I feel like they talk that a lot because obviously the position of the fetus is now moved. And I just keep picturing that. Do you remember that image on the USMLE? Like, I don't remember. It's one of the really early ones where the fetus's hand is reaching out of the uterus.
It's like a horror movie. Oh, thank you. What's the number one risk for uterine rupture? This is definitely a board test
prior
question.
C-section.
Definitely, 100%. Definitely, and that is such a board test question. Cool, and then it's usually like hey, this patient needs to go to the OR like within
Right
5
now.
minutes, hopefully.
Yeah.
Hopefully you never see this as an emergency doctor. The only reason I can imagine us facing this is if the patient is literally like baby's crowning, you're delivering, and this is it. Like you have to deliver the patient. This happens right in front of you in the ED. Or they're a home birth and they somehow come through the ED, which also both of those situations sound absolutely awful and bad luck. And if that happens to you, you should probably get a different job at another hospital.
Gosh, if the baby's crowning and then all of a sudden it gets sucked away.
Yeah.
Oh.
Like a horror movie. Anyway, cool. Hey, if you like these pearls, check out EM Rapid Bombs. Go to our website, emboardbombs.com, and you get over 570 episodes in counting with EM Board Bombs. Pretty awesome stuff. Check out our merch page as well. Go to emboardbombs.com. One click sign up for the podcast and the merch page. How could you not like free merch? Well, free shipping.
Yeah, free shipping for your cool merch.
You have to pay. You have to pay for the merch. Yeah,
Stickers are really cool. You'll love them, I promise.
Yes, you promise. Yeah. We'll see you next time.